Welcome to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few tips before we get started. Your audio has been muted. Please use the Q&A function of Zoom platform to ask questions. Questions will be answered at the end of the presentation. Today's webinar is being recorded, as Becky said, and you will be able to access everything on the National TRC YouTube channel. Today's webinar is presented by Mid-Atlantic Telehealth Resource Center. It's my pleasure to introduce a tag team presentation from Kim Schwartz of the Roanoke-Chowan Community Health Center, Bonnie Britton from Reconnect for Health, and Jay Ostrowski with Behavioral Health Innovation. So please join me in welcoming them.
All right, hang on, let me give me control back there. I'm going to switch the slides. Hang on. All right, quit messing with your mouse. And I'm going to pass the slides over to Kim. There you go.
In North.
I'm sorry, Kim, you're unmuted now.
Oh, you got me now?
Yep.
There we go. Let's start again. Hello, everybody. I'm Kim Schwartz, and I'm the CEO at Roanoke-Chowan Community Health Center, located in northeastern North Carolina. So a little inwards from the Outer Banks of North Carolina. So the objectives today, you will learn about the HRSA OAT grant funding. OAT is the Office for the Advancement of Telehealth, and specifically about our 3-year remote patient monitoring project, our RPM program, and the foundation for the Toolkit. You'll gain insights and lessons learned and best practices for successful program implementation, and you'll get a glimpse of a new toolkit aimed at helping organizations implement the RPM program. So our project, as you can see already from the logos on the screen, that we had multiple grant program participants that were really, this is kind of an amazing thing for OAT to be able to fund a project that was coast to coast. This is the first time they've ever done anything like this. We were a previous OAT grantee in 2010 that expanded our remote patient monitoring model for chronic disease management within primary care in North Carolina. And so we wanted to demonstrate that we could replicate this model to any other health center or any other primary care clinic across the country. So we were really, really fortunate to have very, very strong partners, including the Mid-Atlantic Telehealth Resource Center, which you've already heard from, the Northwest Regional Telehealth Resource Center, Mosaic Medical, which is another FQHC located in Bend, Oregon, and I'll talk about them in a minute, the Central Oregon Health Council, which I'll also reference in a few moments, our Community Health Center, which we were replicating and scaling our model that had an 8-year history, and then OCHN, which is our health center controlled network that ran our electronic medical records. Both Mosaic and our Community Health Center, Roanoke-Chowan Community Health Center, are member organizations of OCHN. It is an Epic-based network. Our partnership also included InScope Health, which added a dynamic that also OAT had never done before by adding a for-profit partner. InScope Health focused more on the technology and the data analytics, and they were responsible for capturing the quantitative data and the grant reporting. This also enabled their system to understand how to replicate this model on a larger, grander scale. They had a history of that, and we did not, so we really were wanting to get their partnership. Move to the next screen. So this is a little bit about Mosaic Medical, which is located right there. You got the map of Oregon. They look like a lot of what community health centers look like. As a FQHCs, we serve vulnerable populations, specifically those that have chronic disease and have challenges related to their health care, often with health disparities, transportation issues, and low health literacy. Their disparities replicated Roanoke-Chowan, so that was also part of the reason why we wanted to be able to partner with them and replicate what we had successfully done in Eastern North Carolina. And they focused on cardiovascular disease, diabetes, and hypertension. Their population was a little larger than our health center and a broader area. So if you've been to Oregon, you know what we're talking about, in a very, very large area, remotely located, and also primarily rural. They do have a slight urban site, but the majority of their patients do live in a rural area. Their population was about 12% uninsured. A lot of folks with Medicaid, and that's what the OHP refers to, the Oregon Health Plan, is also a reason why we included Mosaic as a partner. That Oregon, the state of Oregon, and the legislature there have a tendency to be much more innovative and creative regarding healthcare solutions, and knew that they would be able to offer that to us more concretely because they'd already had some of the lessons learned. And then they do have some Medicare and some private insurance. So looks a whole lot like what most community health centers look like. One of the unique features of this project was that they were a part of what they called CCOs, or now we commonly know them as ACOs, Accountable Care Organizations. Oregon and the Mosaic Partnership were robust members of a regional CCO, and they were also our partner, as I referenced in this Oregon, the Central Oregon Health Network, which included multiple providers in that behavioral health, primary care, a private for-practice profit practice as well, and the local behavioral health hospital and local hospital systems. So our intent was to be able to replicate and integrate remote patient monitoring as part of their community plans of care. So the program results, we just actually were able to extend through this year in February. So over the 3-year grant period, we supported 426 unduplicated patients, which is an incredible thing to manage. It was amazing that we were able to get to that many patients. A total of 455 patients, because we were able to add folks from the first year. They added them back in the third year that were able to benefit from the program with a different chronic disease, as you could imagine. And then some of the key lessons that we learned. This was really the Telehealth Resource Center's idea, and we are so pleased with this, that we kept a running blog of what was going on with the project from the very beginning all the way through. We were pretty robust at the beginning because we had lots of things that we had to learn, lots of barriers, lots of challenges on replicating a model coast to coast, but we had a lot of enthusiasm. And one of the wonderful things was that the site manager was consistent all the way through, because in a project like this, often you have a lot of turnover, and the site manager was consistent all the way through the project, so that definitely helped. We had standing conference calls. We started every week, and then we went to every other week, and we stayed every other week the whole time. And I would say that was one of our great strengths, is that we got to talk to each other regularly and check in and see what was going on. And sometimes it was just a standing call for about 15 minutes, and sometimes we used every bit of that 60 minutes. So it definitely helped us advance the administrative components of it, the clinical, the process, and the technology. So you have the blog right there, and you can log in at any time, and it'll kind of see you walk along some of the issues that we came across on a regular basis. Some pictures out there, some of the team, and it was a great way to have a real live living journal of what we were doing along in the project. One of the major goals of this project was to come out with something that we could use, that we could share for anyone who wanted to replicate a remote patient monitoring program. And for us, we felt like we wanted to be transparent about that, and be able to do that as part of our project. So that's a great transition into what you're gonna learn today. So I'm gonna pass this along to Bonnie Britton. And I do want to say and acknowledge that Bonnie was our first project officer for our telehealth network grant and was a member of our team here at Roanoke-Chowan Community Health Center. So we happen to live in North Carolina and Eastern North Carolina together, but she had the vision for this program to start out with, and she is known nationally as someone that has great vision and history of successfully implementing remote patient monitoring. So we felt really fortunate that we had her here, and you are getting the best expert that I know on RPM, and has been able to develop this. So we're very fortunate.
I'm muted.
There you go.
Okay. Kim, thank you for the kind words. Welcome, everyone. I'm so glad to see we have 90 participants. That's very exciting. We've put a lot of work into analyzing or taking all of the information that Kim and their team collected over the 3 years, from their blogs to interviews that were conducted, the outcomes that they had received. And my part of this was to take all of that information and condense and collate all that information into broad categories. And then, so here are all the broad categories that we broke this out into, but we're going to go into each one, and the details of all of this information, because I'm just going to capture highlights under each category, is available, and Jay will show you how, during his presentation, how to access the comprehensive 8-page or 9-page toolkit. So, why isn't it moving? Okay, here we go. So the first component was the administration of the program, and this is probably the most important component, especially in the beginning. It's extremely critical to understand what the value of remote patient monitoring may be and how to set up benchmarks and goals to accomplish. And you have to make sure that those goals align with the vision and the mission of the healthcare system. And so a lot of time and attention needs to be spent in making sure everything's in alignment and that there's the support of the finance department within the organization to be able to pull the data that is needed. The second component is your basic project planning management. And I guess what I want to say here, because everybody knows basically what that is, but this is where you need to clearly identify the roles of each one involved, determine if you're going to do an EMR integration, what components you want integrated to that EHR. Everybody does not want live data entering into their EHR. Making sure there's memorandums of agreement, BAAs, and as well as workflow assignments. And then the next component is patient population. And I spend a lot of time with groups trying to identify patient populations because people tend to only focus on cardiovascular disease, pulmonary, and diabetes. And they're really Medicare or Medicaid populations. But I encourage you to really look at an analysis of your financial outcomes. And you may be surprised that other patient populations that are also self-pay are a great financial return on investment. The next thing are program resources. I've been doing this now for a little over 20 years, and organizations tend to get caught up in evaluating devices and putting all their focus on vetting devices. Well, you know, we've been doing this now over 20 years. All vendors' devices are FDA approved. So it really is a matter of focusing on software, who you can have as partnerships, as well as what human and material resources do you need available locally, such as patient education, marketing, all of those components. It's very, very important. And then the last thing under administration is having a patient consent to this program, and then to have a competency validation process and form to be able to have, so the Joint Commission comes in and they want to know how this patient was trained on the remote patient monitoring, that you can respond to that and have that available. Also under administration, inclusion and exclusion criteria. Historically, people focus primarily on really strict inclusion criteria or really strict exclusion criteria. I tend to be one that likes to have an opt-out. So if you have a value proposition with heart failure in your organization, then taking the approach of everyone that comes through with heart failure is eligible for this program, and then patients opt out. So it's something I'd encourage you to think about, or if you want to discuss further, contact. The other thing that people don't spend enough time on is the actual clinical workflows. Every organization, whether it's a clinic, a hospital, there's established clinical workflows. So it's critical to understand your current workflows so that you can determine who's going to identify these patients, who's going to refer them, who's going to enroll that patient, who's going to do that installation, what is going to happen when there's an alert, what is the time frame for that alert escalation, who are you going to escalate it to, are you going to send it to primary care, are you going to do that by phone, fax, or through the EHR? Other important components are patient education, particularly on the use of the equipment and the correct way to take their readings, such as the American Heart Association recommends all hypertension patients take 3 blood pressure readings at one, consecutively, getting up in the morning, voiding before you weigh, etc. Then documentation, you have to determine what and where you want do you want it the encounter documented in the vendor's software, or do you want that within your EHR? And then the de-installation workflow. How is that equipment going to come back in? Is someone going to go out and retrieve it? Are those patients going to ship that equipment back to you? So I would really emphasize spending time on examining current workflows and identifying who, what, and when all of these things can be accomplished. Return on investment sustainability plan. Probably of everything I'm going to say today, this is the most important. It's critical for you to work with the financial department within your organization to, again, identify patients you're losing money on, but to develop that financial evaluation plan and assure that they will pull the data that is needed before, during, and following remote patient monitoring, and then analyze that data. Without that, no matter how good your stories are from your patients and success, without that financial return on investment, your program is not going to succeed. So it's critical that you present that to a financial person in financial terms, not in clinical terms. EHR integration, everybody wants it, but everybody's not quite sure what they want. So if you're going to thinking about integrate, partner very early with your EHR vendor, knowing that this is very time intensive and it's going to take a lot of resources. The recommendations from this grant, where all alerts need to flow into a remote patient monitoring encounter that can be routed to the primary care, and that's how they built that that workflow. I think it's always important to have validated, actionable data that then flows into the remote patient monitoring encounter note, so that physicians are not receiving data that is not accurate. It's critical to have smart phrases for RNs as well as primary cares to be able to respond to the encounter, to be able to keep this as efficient as possible. Staffing, it's important to design your conceptual model. Are you going to use internal staff? Are you going to hire staff? Are you going to outsource staffing to do that? Of course, if you do it internally, you're going to need to cross-train staff. I've found that one of the greatest reasons for failure historically with remote patient monitoring is there's not a dedicated person dedicated to that project, and having a clinical champion is absolutely paramount. Whether that's a physician clinical champion, a nurse clinical champion, an administrative, either of those or all three is even better. You need to define those job descriptions, and what was recommended is that consistent management be available from beginning to end, so that there's a consistent message and theme to the program. Training, clinical staff need to understand what remote patient monitoring is, what the purpose of it is. the patient populations, how to enroll those patients and engage in those workflows, review all those clinical workflows so everyone understands what they're doing. And then, of course, you're going to have on-hands training of the vendors' devices as well as software. And I always recommend when you go live, have the vendor on site so that they can actually go in the home with you to conduct in-home patient installations, 3, 4, 5 patients, so that when they leave, you're actually live and your program is up and running. Communication, you can't say enough about communication. All of you know that. You know, internally, it's essential to keep sharing success stories, outcomes as soon as possible. What is going to be the frequency of that communication? How are you going to communicate that to your staff, to your providers? And then externally, who are you going to communicate with? Are you going to try to partner with payers? Are you going to try to share data with payers or with other key stakeholders in your healthcare community that can partner with you for sustainability? And then to me, most importantly, is that consistent communication with patients, focusing on patient engagement and learning to make the correlation between what they did and did not do yesterday and how they feel today to create long-term behavior change. Home installation. In the past, you had to do home installations. There's a lot of companies now that say they can ship the devices directly to the home and the patient can install. I've had a little experience with that being factual. I hope that it will be in the near future. We're closer than we've ever been. But I really believe for patients to be successful, they have to understand how to use those devices. Someone needs to demonstrate that use. The patient needs to return that demonstration, and then competency validation. Also, we recommend reviewing the patient's medication and setting goals. And then when you go to the toolkit, there is an RN visit checklist that we recommend to keep the nurses focused and efficient when they're in the home with patients. And then outcomes, patient satisfaction. You can develop a patient satisfaction survey, provider satisfaction. Looking at your clinical health outcomes, is that hemoglobin A1Cs and glucose for diabetics, LDLs, and height, weight, and blood pressure for cardiovascular disease. And what you want to do is look at trends over time and be able to graph the progress of a patient from the beginning to end to see if they're improving their health, maintaining, or if they're slipping down. And then, of course, meeting that budget and making sure you stay within your budgetary restrictions. Devices, this first statement seems to be a no-brainer, but start with new devices. Some programs start with patients with devices that are not new and that can create a lot of difficulty in the acceptance of technology from the clinical staff as well as from the patient end. And then always remember, when you have devices, you've got to receive, inventory, tag, and store those devices. You have to install, deinstall, and then clean those devices. And then there's that inventory management. A lot of health plans are outsourcing this component for really large programs because it is very time consuming, and you need to make sure you've got enough resources to be able to manage have that device management. Or identify a department within your hospital, such as the biomedical department, who could do that for you. And I know I covered that very quickly, but at the end, we're going to take questions and answers. And now, so I took all that information from Kim's group, and then I gave all of this information to Jay. And now Jay's going to show you what he has created that will be on the National Telehealth Resource Center website and how you can access this entire toolkit. Jay?
Hi, everybody. I'm Jay Ostrowski with Behavioral Health Innovation, and I'm one of the consultative partners with the Mid-Atlantic Telehealth Resource Center. And I work very closely with Bonnie Britton, and Bonnie and I both kind of cross over many departments where my specialization is in telemental health, telebehavioral health. I also work on general telehealth initiatives because it's frankly just involved in a lot of problem solving in the general telehealth space. So there's a kind of a lot of crossover here. As we have helped many companies deploy these kind of services, one of the things that we understand is that it feels like drinking from a fire hose. There's just so much information. And having helped roll out other toolkits, we were really kind of thinking, how do we help people kind of catch this vision for one? But then the other part is we know that if you're starting this up or you're trying to champion this in your organization, sometimes it's a tough sell to kind of package this for people and help them kind of understand, here's the value proposition of this. And we know that the people that we're working with don't always read quite a lot, even though they're capable, they don't read the documents we give them. So we're thinking, what's a way we could kind of capture their imagination, help them kind of get their heart and mind on board, and then also to help kind of really condense just the idea of what are the key roles that need to take place in implementing RPM, and then kind of what's the scope of those roles, and then how do those roles fit together, and where are kind of some of the general lines in between them. So we thought we would take this broad information and basically kind of make it more of like a pyramid where you start with a little bit at first to kind of get enough of a taste, and then you can drill down in each role and get a little bit more and a little bit more. So what I'm going to do is show you the site that we made for this. And we put it on let me share my screen here. I'm sharing my screen now, and what we have on the screen is, it's at a placeholder site, telehealthdirectory.org. It'll be there for the next month, and we're migrating it to the National Telehealth Resource Center site. But what's on this site is basically a quick video to help that you can share with your management and coworkers to help them understand, here's the general vision and here's what happens in remote patient monitoring.
Patient monitoring helps supplement a patient's care. It is proactive care rather than a 24/7 triage service. RPM provides information on the patient's health trends that help mitigate complications or repeat hospitalizations. Deploying RPM successfully is a synergy of various roles, ranging from executives making policies to nurses providing care. RPM is simple when each role knows their part and has been proven to improve a patient's health. Click your role to learn the part you'll play in remote patient monitoring.
So that's something that you can share with, again, your coworkers or your management to help them understand kind of what's the overview and what's the overall purpose and roles here. And then each role is kind of broken down individually, so an executive can know what is their part and what does the RPM team need from this executive. So we have a little bit of a video there for that. The next one is the provider. So this is the clinician involved. Many people think that a clinician has to prescribe RPM, and that's actually not necessarily true. It could be a standalone project independent of the physicians. However, you need the physician's involvement as they're often the ones introducing this to the patient, and they need to be supportive. And so we talk a little bit about what is their role in this. We have a little video for them. And then, of course, the nurse. What is the nurse's role in this? How are they a part of this project? And what are the parameters, the scope for them? And then finally, we name this role technician. It could be named many things, and sometimes the technician is combined with a nurse, or sometimes it's a different department. But it's the person that are actually managing implementation of devices and managing that inventory, as Bonnie described earlier. So with each of these roles, the person that has that role can kind of drill down into it. The overall project manager that's trying to launch this initiative can use this as a tool to help their organization kind of understand what's involved, what's the scope. And then for each of these roles, you can drill down and see there's again the video. And then we talked about here's what's the role, here's what the responsibilities are, here are the outcomes. And then we have a link to the entire document that Bonnie referenced a moment ago. So for each role, again, you can click on nurse and see what's involved. What does the nurse need to do? What are their what's the overview? What are their responsibilities? And then the drill down into the documentation that Bonnie's created for this project. We understand again that this is a lot of information at once, and it's hard to condense it all and kind of present it to others. So we're hoping that this tool will be a way for you to easily communicate with others how to go about starting. And then, of course, the telehealth resources centers are available to help you implement that once you are ready. So, Kathy?
All right. So we have some time for some Q&A, and I think Becky's already answered a few of those. But one question is, did you have any vendor support? That would probably go to Kim or Bonnie.
Kim.
Yes, let me get my video back on here. Yes, we actually did. Our vendor was Ideal Life for this particular project, and we've been working with Ideal Life for many years. In fact, I believe we were their second contract. They really were quite helpful because they were out in California. So when Bonnie talks about having equipment directly shipped there, we were able to do that, not have to ship it to North Carolina first and then ship it to Oregon. So Ideal Life was really instrumental in offering training. They offer technical assistance. Our representative actually from Ideal Life actually went to the Mosaic site and walked them through a couple of things, which was really, really helpful. So although they weren't technically a partner, they were our vendor of choice. Now we broke Bonnie's rule there in that we used old equipment. We learned that wasn't a good rule. That was a good rule that she established, but it was because we had purchased this equipment with the first OAT grant, and so we wanted to replicate that, and we wanted to use that equipment. So that actually got our costs down for the grant, which was very, very helpful. So, but we found very, very quickly that some of that equipment worked great, and some of it didn't, and we had to really mess with have options for the service area, meaning that there were still a lot of folks out there who had landlines, and we had to be able to work with Ideal Life on option for landline because they only had cellular based, and then they had different cellular options, and we had to go with one. And so they were really, really instrumental in helping us cross over those issues. You know, as Bonnie mentioned, the equipment all is FDA approved generally around, but it is the software issues that are, how are they going to be able to maximize that? We had to work very, very closely with Ideal Life we did integrate into the Epic-based system, the Ocean system. And I wish I could tell you that was a very smooth, easygoing, seamless process, but it took 4 years. Yeah, so perseverance is the name of the game.
So that got to half of the question about which EMR vendor did you use, and then the rest of that question is, did you copy and paste into the EMR, or was there an interface?
So we did both, as you can imagine. So we did copy and paste. We did have smart phrases we had already developed in our project, so we were able to replicate those. But Mosaic actually had much more advanced resources than we did. They have a whole IT team. You may recall Oregon expanded Medicaid, so they had some more resources than we did. So their team actually developed quite a sophisticated touches system that enabled them to monitor how many times a patient was touched, what the length of time was, and so they were able to actually advance that more with much more sophistication than we had up to that point. So, and that was through the Epic-based system.
Right. The next question is for probably both Bonnie and Jay. Are you able to give examples of your RN checklist? And I believe that is actually in the toolkit, but Bonnie can talk about that. And Jay, maybe you can actually demonstrate it.
Yep, it actually is included in the toolkit. So when you go onto that site and you click down to the toolkit, it's probably a little past midway through the document. But it talks about that all the things listed for the toolkit are there. You could take that information and actually put it on in a format that you would want. We didn't place it in a format for the toolkit, but you certainly can do that.
And I would add, you know, having worked with a lot of organizations implementing services like this, we found that the checklists are a good starting place, but they're not the ending place. They're kind of a generalization, and then you have your individual workflows that really fit your own organization, your population, your resources, and kind of, so your process flow will be a little bit tailored. So again, I think it's good to know it's a starting place, and the entire document is kind of it's one example of how one program was able to put it into their workplace. And it's something that can be replicated, but in every case, it will need a little bit of individualization and customization. And again, I think that's where the resource centers are great at providing some of that support for you.
And this one is for Kim. How did you measure low health literacy?
We actually integrated the PAM, the Patient Activation Measure tool, out of Oregon. It was created out of the University of Oregon, and we're able to use that scoring process for measuring that. We actually had that as one of our key measures from the beginning of the patient integration into the project to the end period, which we did find an increase in that, so that folks had a better understanding of their own health literacy with utilizing the PAM. They do not permit an integration into your EHR, so they keep that pretty highly guarded, but it is a very reliable tool. We found it to be very, very helpful, and they were generous in giving us, knowing that this was actually a part of a HRSA project, they were generous in giving us a low licensing renewal for that. So it's a great tool.
All right, next question. What role is there for policymakers such as state Medicaid agencies in promoting remote patient monitoring?
Well, I'll take a first stab at that, and then I know Bonnie and Jay can jump in on that, and Kathy as well too. There is not a code for RPM that you'd put an ICD-10 code, which that is something that we've all been advocating for from the very beginning. I would say policymakers have a much greater understanding than they ever have because of the shift to value-based care, and helping policymakers understand that RPM is part of the larger population health focused and will give you better outcomes in a value-based system. And that I call it grits and grace. Everybody that has chronic disease should have remote patient monitoring. It is not a rural issue. It is not an urban issue. It is a patient access issue, being able to have that as a source. So fortunately, through a lot of advocacy, a lot of work with the American Telehealth Association, the Telehealth Resource Centers, there's now a chronic care management code in Medicare. And now in January, if everything goes through, there will be an advanced chronic care management code. Now, I will tell you from our numbers and doing this for a long time, the average cost per month for us runs between $150 and $200 a month for monitoring a patient. The chronic care management is the reimbursements between, around $40 a month. So that doesn't cover your cost, but in the value-based system, it will pay back in the long run. So helping policymakers understand to include that as an allowable cost in cost reporting has been a great help to us. And enabling services and FQHCs, that's an eligible cost as well too, and in nursing visits to be able to use RPM eligible for nursing visits. But policymakers need to understand the long game in this, and that's harder for them to do. But that from our standpoint as an FQHC, and we received cost-based reimbursement, we add the cost of RPM into our cost-based reimbursement.
Bonnie, you have anything to add?
I don't think so. Kim, you covered it very well.
All right.
I would add that sometimes I think we need to package the information well to get it to people to basically sell it to legislators and even to lobby for it. So sometimes we look at some of these numbers and there are different kind of implementation models that bring down the costs, and so there's some differences there. But I think finding the touch points of where are the priorities and where are the points of pain that where the problems we're trying to solve, and showing kind of the broad way we can solve multiple problems with people with multiple different chronic care conditions. We can attend to that fairly efficiently with kind of new processes and new softwares available. So I think some of it is again presenting the latest information. So there's a lot of information out there, and a lot of it ages quickly over time. There's also some misinformation out there. So we're trying to kind of collate that and bring the best and serve it up so we can make it kind of easier for different organizations to start implementing this as soon as possible.
Okay, we have a question in the chat. How long was a typical user on the RPM device?
So for our project, we did a 6-month enrollment with an optional 3-month extension. So they averaged the 9 months. So most folks needed the extension because we put them on because they were high-risk patients to begin with. So in our model, that's how we use that. I see also that someone has asked the question about what was the ROI that we focused on. And so that's a key focus to RPM in general. So the ROI we focused on was a couple of things. So we wanted to reduce ED visits and maximize the appropriate right time, right care, right utilization of services. So that was a big deal that we wanted to replicate, and we had some really good success with that. The other was to expand access to care, especially in the remote area, because the Office for the Advancement of Telehealth has to focus on a rural area, and so that was a key component of extending access for those, and to coordinate and improve the quality of health care in multiple care settings. And that was a focus of this, integrating the specialty, the behavioral health, and just the community as they are a CCO. And then a key component was tracking the total cost of care. So although we weren't always able to get the data, Medicaid we were pretty able to do that, but the other payer sources were a little more challenging. But because it was a CCO, we were able to get Medicare data on that. So we're trying to track the total cost of care for those enrollees. So that was how we measured the ROI.
And
go ahead, Bonnie.
I'd like to add also, from an FQHC perspective, what Kim stated is absolutely accurate. But if you're in a health system or a hospital, it may be that you're looking at reducing less than 30-day readmissions. Mm-hmm. It may be that you're trying to keep self-pay patients or patients who have Obamacare and huge deductibles that can't reach and ever pay those deductibles and it's write-offs. So I think the real key is drilling down into that financial data with the CFO team to figure out where you're hurting the most. Let me give you an example. We were recently working with an organization, and they thought that, and this is an academic medical center hospital, they thought their greatest losses were on Medicare, heart failure readmission, COPD, etc. What we found after doing a pilot and analyzing the data, each heart failure patient, they were losing about $900. But on their self-pay patients, they were losing over $9,000 a visit. So that's where you have to drill down and really figure out where are you hurting financially. Implement that population first to gain your buy-in, and then you can roll that out over time.
Excellent, thank you. So next question, were you able to do RPM integration into Epic, and how do providers react to getting all these biometrics into the record?
Yes, we were able to do RPM integration into Epic. That was quite a, as I mentioned, quite a process. We utilized the Touches system that was developed by OCHIN and then able to track it that way and summarized for the providers. I think even from the very beginning, we were anxious about how the providers would respond to getting that data and where to find it. And that was one of the things that we were able to address, the isolation in the chart of where to find that. So we had a continuity of care component in the chart, and that actually answered and addressed our patient-centered medical home requirement as a certified patient-centered medical home. So that was really a helpful component for them to see. I think was even more important that they relied on so that they didn't have to look at all the data. I've always heard this, and it has played out in research and in reality. They don't necessarily want to see all that data at one time, but if they want to see it, they want to have access to it. So what we did was that we continued with every 2-week summary that came right from their nurse, and we had a formula for that that they were able to effectively use it, and that app actually scaled the model that we had. So the best part was the relationship with that nurse care manager. They did the same thing in Mosaic that we did here. They had one person that was a point of contact, and not multiple, so they got a consistent message from a remote patient monitor nurse care manager. And then we had they had a couple of folks that also worked with them that were mid-level providers as well too, that were designated for RPM. So that was one of the things that we learned early on. Don't open it up to every provider to start out with. Target champion providers. And that helped. And we started out at the Prineville clinic that they had in Oregon, and got some champions right away on that. And being able to find out there as a provider, they had a lot of input on what they wanted the record to look like.
And did you encounter any hesitance because it placed them in a sense of liability if something was not addressed?
So that was something that we had learned in our project. And so we made sure that that was a component that the care managers followed. So if something wasn't addressed, that was for us an out of perimeter issue. So they couldn't close the chart until that was addressed. So it had to be addressed by someone. So that took the liability off the provider. Of course, we're covered under Federal Tort Claims Act as a FQHC, and that helped us, and that's a little bit of security. But providers are appropriately cautious of that, and making sure that there were answers to that has always been our closing the loop. And that helped in the patient-centered medical home loop as well too, because that has to be closed because of patient-centered medical home.
Excellent.
So, and I would add, in different implementations, the provider or the provider group wants different levels of access to that data, as you mentioned. What they don't want is typically a lot of noise and a lot of clutter. So there are different ways to go back that, and we can help you with some options there where all the data could be available, even the precise data and the trend data over time. But again, you want it only accessible when they want it, and not kind of in the way or cluttering up the chart. The other thing I was going to just address quickly is the devices themselves. I think when Bonnie was saying that they're all FDA approved, I think she's referring to like the kind of the top the general the vendors out there. I wouldn't say anything from China that is just sent your way is compliant, but most of the major industry players in here, and we can give you some guidance on kind of a scope of ones to use. Have worked very hard with the FDA to be compliant. So we just want to, kind of mention that.
Thank you.
And then go ahead, Bonnie.
No, I said thank you.
Yeah. And then there was a question that came through about behavioral health. So that's my area of expertise is telebehavioral, telemental health. And then the question asked, with behavioral health, do you see the need for video? And I'm not quite sure if they are meaning, do you need video for behavioral health, or if you do behavioral health, do you need video if you're doing it remotely? The best practice at this point is to use video for telebehavioral or telemental health. And there are some protocols that you would need to do if you're doing that clinic to clinic or direct to consumer. If you want to, send us a message at any of the TRCs, we can lead you to some trainings that are, vetted by other professionals in the telemental health industry, and also give you best practices and technology guidelines and a whole bunch of information to help you guys get started there as well.
Okay, speaking of home health, was home health utilized?
In our project, no, we don't have a certified home health program, but the original model that Bonnie brought into our community health center was derived out of a robust home health model, but then we integrated that into as a primary care. So I will tell you that every patient did have a home visit. So that was our part of our protocol. And the first visit that our team actually went out to help them engage and start the first enrollment. And so our team thought we knew remote in Eastern North Carolina, and we've got some good swamps and some things you have to crawl through here. But they, by accident, because they used my AARP discount, they were able to get a 4-wheel drive at the airport when they rented, and they were pretty grateful because one of the folks that they did an installation on in Oregon was out of the mountains, the beautiful mountains out of Prineville. So the road ended, the official road ended, and then they had another 30 minutes of dirt road to get to a patient's home, and they were on a generator. So they were grateful that our lessons learned were take every kind of device that you could potentially use so you didn't have to come back. So they were very grateful for the 4-wheel drive. So, but in that home visit, we had a protocol. So we used a similar home health model protocol where we did a home check, safety check, talked about the rugs, did a whole kind of home assessment in that. So although we didn't use a home health as part of our model, we actually used a lot of those guidelines in establishing our protocols.
Right. And is your RPM model centralized or more integrated into the clinical care unit sites?
I am happy to say our model is completely integrated into the whole system. So it took us a little while as an organization, and same with Mosaic. It took a little while, and it takes about that 3 years to adapt the culture to, oh, this is a part of our menu. This is a part of what we offer our patients. So it's a part of our chronic disease management offerings at our community health center, and it was with Mosaic as well.
So you already mentioned that your Epic was electronically integrated, but it took 4 years. So prior to full integration, did you do the scanning of the patient summary report into the system?
We did. That was really the only way to do it. As we had a location in the chart, and I also have to tell you that we went through 3 Epic upgrades during that process. So every time we had to go find it again. But that's the nature of working with EHRs. So yeah, we did scan it. We still today do mostly scanning. Our system we don't quite have the workflow for our team, but we have a lot of seasoned providers, and that it's been a little easier. We are tracking the data, however, that way. We are tracking it through discrete fields in our EHR.
All right, and was staff or workforce hour measures monitored as part of the ROI, and if so, what were the findings?
That would have been a great thing to do. I would tell you, as some of our lessons learned, we recognized pretty early on that we needed more FTE support, backup support, because we'd one identified RN for the project and then an assistant for installations, and learned really early on that we needed to have more backup, so that when they were out, and that some of it just was just logistics, how far away some folks were for installations. So we did recognize that we really thought that one RN could manage about 80 patients, and it was really a little bit less than that. So the most they had was at some time, they were when we had 80 patients, it was frantic because of the come and going of enrollment and disenrollment, and we didn't have everybody on the same schedule intentionally because of equipment. So I know we did a little bit of PDSA work on the total time for installations. So because that was much different than we had in North Carolina, but not total use time.
And Jay, did you want to take one of those?
Sure. So there's a question here that says, for Jay, do you have experience doing telepsychiatry with complex mental health disorders such as PTSD and bipolar, where patients come to community health primary care clinic and receive medical and behavioral health care later through video conferencing? So yes, I have experience personally. I'm not a psychiatrist, I'm a licensed counselor, but helping programs set up those use cases. There is a lot of data that we can provide and use cases for this and set up both for clinic to clinic work and clinic to home, direct to patient home. There's some protocols there, but dealing with treatment resistant populations, a lot of it is really about the provider's rapport with them and relationship with them, and building kind of a use case that they will buy into to do this. But we have found a lot of people really enjoy that at-home care and feel a bit special by that. And so once that's set up, there's actually data showing a reduced number of no-shows in the clinic, which is a big benefit all by itself. So I do believe it's pretty clear that mental health care helps people manage their general health care. If you're depressed or anxious or psychotic, you're not going to be taking your meds and exercising and eating right. So again, it's a kind of a no-brainer partnership with remote patient monitoring because we can, once we have this relationship and we're setting up this equipment and doing this, having an internet connection, we can set up pretty simply video conferencing in the home for a clinician to intervene when that's needed. Or, I know in Bonnie's work, sometimes they will do a phone call or a video call just to say, hey, we noticed your readings are high. Can we walk you through doing that again? Or let's talk about your diet, or that Chinese food you ate last night is kind of wreaking havoc on your measures. So Bonnie might want to address that as well.
Absolutely. We have found with direct-to-consumer as well as patients being discharged post-hospitalization for remote patient monitoring, having that video capability once you have abnormal readings and you're talking to that patient, being able to have a HIPAA-secure platform to be able to very easily make a connection on demand or a scheduled episode is very important, not only from nursing or therapist perspective, but nutritionists as well as physical therapists, occupational therapists, anyone that could benefit from seeing that patient's their movements, their activity, etc. So I started remote patient monitoring 20 plus years ago, and all they had was video based with peripherals, and then the video kind of went out of vogue, and now it's coming back into vogue. But now there's so many super easy video platforms to utilize to be able to have that access to patients.
Right, Jim, do you want to jump in and answer?
Sure. So what the question was, when a patient needed intervention, who followed up? So because each one of those patients had an individual plan of care, if they were out of the measure that was set by their primary care provider, we followed that trend. So that nurse contacted them generally by phone, so it was a nurse that contacted them. We had the care manager who did the installations also monitored key measures. So they would monitor by trend the diabetic readings, the weights, and we had some algorithms built in because the Idea Life equipment was that sophisticated to be able to do that. But it was a combination of some compliance level and then nurse level. That phone call was one of the keys, is to find out what was really going on and then to document that and communicate that back to the provider. So generally the provider did not call. The provider would indicate whether they wanted a visit unless the nurse said, would you please call this patient? And so they relied on the nurse to do the needs assessment in that setting. So we have found an RN really helps with that the RN can make that needs assessment and give that engagement. On some occasions, we did go out and do a second home visit. Often if the patient needed it, you could tell. I mean, they were dealing with the same panel of folks, and they could tell if that's what they might have needed that extra. So it was very, very targeted to that patient's need.
And we are unfortunately out of time. While Becky's flipping back to the slides, I guess we could do one last question, which is the ratio of patient to monitoring nurse.
Yes, I think I answered that earlier. Our target was 1 RN to about 80 patients, and we averaged probably about 70, somewhere between 60 and 70 per 1 RN, although we added a little FT in there for help and supplemental support. So that's what we found was helpful in that situation and with that grant.
Great. And we did have financial data, and we've actually done previous webinars that had the financial data. And if you want to either email me or I'll go visit the TRC website, we can point you to those webinars where that financial data was presented. So I want to thank you for joining us. This presentation has been part of the National TRC webinar series. The next webinar is scheduled for September 21st, and it's going to be focused on Telehealth Connect, which is our mapping tool, which is moving to the national website next month, and you can really learn how to use it to either determine whether your site is eligible for Medicare reimbursement, or use it to understand where the telehealth providers are located in your area, or to find telehealth providers. And so that's going to be a really good tool for you all to have.
And how to get listed if you're a new telehealth provider.
Right. And then we really value your opinion, so we would love for you just to take a brief moment. If you enjoyed this webinar, if you felt like there were some things that could have been improved, we would love to get your input. And so if you can click on that link or go to that link and complete the online survey, we would greatly appreciate it. Thank you for your time.
Bye-bye. Thank you.